So Ganesh, being at an academic institution and having a multidisciplinary approach, and I've had the pleasure of spending the day with you guys. So when you guys are seeing these patients, how does that work? Is Kathy over in medical oncology, is she doing a lot of this, or in terms of imaging? How do they, are you working with them closely? How are you guys monitoring those patients in terms of that particular environment?
So that's a good question. I think certainly I practice in a different environment than all of you guys do. We have the benefit of being around some very smart medical oncologists who work in the exact same clinic, as you say, where I am into the University of Michigan Cancer Center. So the answer is it actually kind of depends. Most of the time, if they're hormone sensitive, we're doing it. Once they get into more of the CRPC sort of stage phase, we sort of shift over to the medical oncologist, and that includes, Maha Hussein, Kathy Cooney, and David Smith primarily, and we have the benefit of really having them there. But the hormone-sensitive state, that's really all us. We're still doing that, and so that's what we're doing in Michigan.
Do the residents or fellows at Michigan, are they spending time with the medical oncologists who are primarily doing a lot of GU oncology, whether it be prostate, whether it be bladder?
Yeah, it's sort of guilt by association, because you can imagine that my clinic, every clinic I have is a multidisciplinary clinic. Every clinic I have, there's a medical oncologist who's seeing patients concurrently and or simultaneously with me in some of these complicated patients. So I have the benefit of not having to wait to shift them to another clinic for another day, another time. It's actually every day, every time, there's always someone there. And so the residents and the trainees with us get to see that one-on-one, sort of that dyad sort of interaction. We also have radiation therapists there as well. So we're very lucky in that regard. The flip side is that I'm much less involved in the advanced prostate cancer therapeutic world than you guys are, because those guys are just there and we just move them over.
Right. Yeah, and it's interesting, and again, even with bigger groups, the model is changing. I think all of us embrace the concept of a and the need for a multidisciplinary approach. And for some people that have radiation oncologists are there, it's easier. We don't offer it, you guys don't offer it, so it becomes a little bit tougher. So so moving on, as these patients progress, and obviously, Chris, as you pointed out, we are going to, if we start looking, because again, we know that PSA, you don't have to have extremely high levels of PSA to have metastatic disease. But once they do have metastatic disease, and again, depending upon whether you use the AUA 6 index patients, whether you go by NCCN, now the great thing for our patients, and I do think it's a great thing, is that we have these tremendous number of agents, all mechanistically different. Obviously, we don't know the sequence, we don't know the combination. We'll probably never see head-to-head studies. This is all going to be done by gestalt, by registries, by field. We're going to have to, again, incorporate some biomolecular testing. But again, a couple of new agents have been approved, especially in the secondary hormonal state. We know that Janssen and Abiraterone Zytiga got approved last year, and because of the COUGAR-302 trial. Neil, can you walk us through 302?
Yeah, so 302, as you said, was looking at abiraterone acetate plus prednisone in comparison to a prednisone and a placebo, prospective trial. Approximately 1,100 patients, global multinational trial, phase 3, and ultimately was approved initially after early interim analyses based upon an obvious delay in progression-free survival of approximately 8 to 9 months, and what was an obvious trend of about 5 months in the overall survival. Just missed the boundary of significance due to what's known as the O'Brien-Fleming rule. Forgetting about all that now, to the company's credit, they had 3 additional interim analyses and then a final analysis, which was just presented at ESMO this year, which is, Chuck Ryan, and I think it's really very laudable of Janssen. They followed the patients out, and even though the FDA gave approval in December 2012 as the first oral oncolytic prior to chemotherapy, we now have the final analysis, which is statistically significant, showing a 4.3-month survival benefit, which to date is, you know, the longest survival benefit of any oral in the pre-chemo space. And so I think that's really good, because you now have this incredibly long, you know, matured data set of roughly 95% of the events, the deaths. So that's where, you know, abiraterone acetate prednisone, also, you know, commercially known as Zytiga, is today.
Right, and again, that data is hot off the press, and so again, their initial approval, as you said, they got approved because their RPFS was statistically significant, but because of the statistical boundary that everybody talks about. But you're right, it's 4.3 months on relative to the other agents is pretty significant. And then